Hello everyone. I'm very happy to join this session. I would like to talk about rehabilitation at home based on interactive telecommunication for patients with hip fracture. I have nothing to disclose here. This is John Hopkins COVID-19 dashboard. This tells us a huge number of COVID-19 patients, over 500 million cases till now. Over 6 million people have died. Although Omicron variant has been dominant virus, the fatality rate is quite decreased. But taken together, the fatal rate is 1.16%. In many countries, the COVID-19 has become almost an endemic situation. However, in global situation, it does not come to an end yet. We have an unprecedented situation in our daily life due to strict social distancing. Wearing masks has become an essential rule everywhere. And teleconference has become our ordinary activity in every workplace. COVID-19 pandemic has put a lot of strain on our healthcare system, which makes it difficult to vulnerable patients to access hospital services. So we found the excess mortality other than COVID-19 mortality case during the pandemic crisis. How did COVID-19 pandemic has an impact on facility fracture care? Lack of attention for the care of old adults who have the risk of fracture because of less priority in pandemic situation, and also less opportunity of rehab services after facility fracture treatment, and isolation and decreased activity lead to poor physical health and increased risk of secondary facility fracture. There have been huge challenge and difficulty of facility fracture care in patients with COVID-19. This is a report from Singapore in the beginning of the pandemic. When they compared 2 months before highest alert level pre-COVID versus 2 months after post-COVID in surgically managed hip fracture patient. Indications of hip fracture surgery remain unchanged, and time to ward and time to surgery were not different. However, a sharp decrease in hip fracture during the COVID-19 pandemic, for 54% decrease was noted. In terms of restriction in managing hip fragility fracture during COVID-19 pandemic, musculoskeletal injury is classified among the conditions less likely risk patient harm if deferred. CDC recommendation is to arrange for in-person care as soon as feasible. With this restriction, patients with hip fracture, if admitted, are quickly discharged after surgery, often without any anti-osteoporotic treatment, proper post-surgical rehabilitation, or further recommendations for follow-up. The data has confirmed the unwelcome consequences of COVID-19 pandemic. In recent results of longitudinal cohort, hip fracture patients in COVID-19 period showed double increase of mortality compared to before the pandemic. On the other hand, length of stay has rather decreased. That means many patients were discharged without proper and enough post-fracture care because of so many reasons such as lack of workforce and less priority. This is a functional trajectory throughout lifelong period where older people usually are vulnerable to acute event, for example, fall and facility fracture. If they are recovered successfully by the proper management, they could return the previous level of function. However, during the pandemic, isolation and inactivity, the patient faced with make more for function worse following acute event, and they would be limited or recovered with severe functional decline. What we need is to manage fragility fracture during the COVID-19 pandemic. New strategies should be implemented to balance the need to provide the necessary health services to the patient with fracture. Alternative model of care are urgently needed. For example, telemedicine tools not only has the potential to improve quality of life and survival outcomes, but also it is cost effectiveness, lowering the economic burden of fracture and saving resources for tackling the COVID-19 pandemic. Furthermore, rehabilitation services has been suspended due to the concern about spreading infection and limitation of workforce during the pandemic. Telemedicine and telerehabilitation are developing rapidly as an alternative model of care. Since 2020, we have started new model of home-based medical care, which is linking between acute hospital care and home-based care. The fees for education, discharge care plan, and home-based monitoring are funded by National Health Insurance. The indication of this model is being expanded to stroke patients who received inpatient neural rehabilitation and pediatric patients with severe disability, patients who need home ventilator care, and so on. Last year, we have started new model of home-based medical care for fragility fracture. Pilot and feasibility trial of rehabilitation at home has been launched at the hospital participating in this project. Interestingly, this program include to provide telehealth services such as education and counseling and regular monitoring for self-management for patients at home. This is to provide necessary medical services at home to patients undergoing fragility fracture. Improving patient satisfaction by linking hospitalization and discharge and rehabilitation at home for patients with fragility fracture. Patients who received major orthopedic surgery, total hip arthroplasty and total knee arthroplasty, and fragility fractures are the main target of this model. Education and discharge care plan and home-based monitoring, including telemonitoring and online communication, are provided to the patient. This is a clinical pathway post-operative care plan for hip fracture. After the surgery, we introduce a home-based program to the patient and their caregivers in the ward. If they agree with participation, the program will start during inpatient care, whether the patient are transferred to a rehab unit or not. If the patient decides to go back to their original place after acute care, they're going to be received 2 sessions inpatient education by home-based multidisciplinary team before discharge to their residence. Then our care coordinator start monitoring the patient with telecommunication, and outpatient education is also given at outpatient clinic in follow-up visit. From the start point, 6 days is the period reimbursed by the insurance in this program. This is the brochure introduced the home-based care program. It is displayed in front of a nursing station to be easily exposed to the patient and their caregivers. This is the document to be used to provide these services. We use these documents embedded in electronic medical record system to prescribe and report and communicate among the multidisciplinary team. We design and create a variety of education material and manuals, easy for the patient to understand. This is for pain management and exercise materials, and gait and activity daily living guidance and hip precautions. This is the education material for osteoporosis management and fall prevention. In patient education session, we explain the purpose of the program and functional status evaluation and pain and coping strategy assessment, and management of postoperative complication, exercise training, and educate how to move in the right way. For patient monitoring, we use the two-way communication with the patient by phone or SMS, occasionally if available video conference. We are conducting and encouraging the proper exercise and guiding the coping strategy and monitoring any complication changes and medical and functional. Let's take a look short video or activity.
통증은 좀 어떠세요, 어머니?
통증이 좀 있어요.
통증 좀 많이 심하실까요, 지금도?
네.
네. 왼쪽 다리 빵! 좋아요. 다시 내리고요. 다시 한 번 더 6, 빵! 여기를 넘겨보면은 우리 하루에 운동 2개씩 체크할 수 있는 란이 있어요.
네.
제가 오늘부터 어머님께 숙제를 2개씩 내드릴 거거든요.
아프실 때 캐프터 붙였는데도 계속 아프시면 그때 드시는 거예요. 이건 그렇게 심장에 좋은 약은 아니라서요. 꼭 필요하신 경우는
감소증은 골다공증보다는 조금 덜한 상태긴 해요. 하지만 지금 시기부터 어머니가 드시는 거라든지 아니면 이렇게 꾸준히 운동을 해주시면 얼마든지 좋아질 수 있어요. 아시겠죠?
As an outcome assessment, number of participants and number of cases and of education and counseling services, and education materials and manuals, and the level of quality of these materials, and the satisfaction with service of participants, and the pain and functional evaluation is included on outcome assessment. I would like to summarize my talk. There have been a bit more challenging and difficulty of fragility fracture care during the pandemic crisis due to lack of attention, less priority, and less opportunity of rehabilitation services and workforce limitation. Telemedicine and telerehabilitation is being developing rapidly as alternative model of care. Rehabilitation at home fragility fracture based on telemonitoring and telecommunication led by multidisciplinary team. I think it could be a promising model of fragility fracture care in post-pandemic era. I would like to say thanks to my colleague and the multidisciplinary team in our hospital. Thank you for your attention. If you have any question, feel free to contact me at any time. Thank you.